Hello everyone! In this mind map, we will be talking about the different classifications of trauma to the teeth and the management of the same. Let us begin with the Ellis and Davy classification. Moving on to another very important classification of trauma, which is the Andreasen's classification. This classification is broadly divided into three categories: injuries to hard dental tissues and pulp, injuries to periodontal tissues, and injuries to the gingiva or the oral mucosa. Starting with injuries to the dental tissues and pulp. Enamel infraction. This is a crack in the enamel that does not go all the way through the tooth. It is usually not painful and does not require any treatment. However, if aesthetic concern is present, layering with composite is done. Enamel fracture. This is a fracture that goes through the enamel only and does not reach the dentin or the pulp. It is also known as uncomplicated crown fracture. It can be painful, but it is usually not serious and can be treated by filling the sharp edges or restoring the fractured edge with composite. Enamel dentin fracture. This is a fracture that goes through the enamel and dentin but not into the pulp. It is another type of uncomplicated crown fracture since there is no pulpal exposure. It is more serious than an enamel fracture, and treatment includes reattachment of the fractured segments, restoring with composite resin, or replacing the tooth with a crown. Complicated crown fracture. This is a fracture that goes through the enamel, dentin, and into the pulp. It is the most serious type of tooth fracture, and it usually requires pulp capping if the exposure is small, and the pulp has been exposed only for 4 to 5 minutes. However, if the exposure is large and the pulp has been exposed for longer than 5 minutes, pulpotomy or root canal treatment has to be done. Complicated crown root fracture. This is a fracture that goes through the enamel, dentin, cementum, and pulp and separates the crown from the root. It is a very serious type of tooth fracture and it may require extraction of the tooth. Root fracture. This is a fracture that occurs in the root portion of the tooth. It can be classified as either a vertical fracture or a horizontal fracture. Vertical fractures are more serious than horizontal fractures. Prognosis depends on the position of the fractured segments. Apical 1/3 fractures have the best prognosis since the tooth remains vital and resorbs normally. In middle 1/3 root fractures, the tooth is mobile and may require extraction. In coronal 1/3 fractures, care should be taken while extraction to prevent damage to the underlying tooth bud, if any. Moving on to the injuries of the periodontal tissues, we have concussion, an injury to tooth supporting structures without any displacement of the tooth. The tooth is tender to percussion and sensitive to biting forces. Slight widening of the PDL space can be seen apically, and the pulp size may be reduced after a few months. Treatment includes relieving the occlusion from the opposing tooth and soft diet for 10 to 14 days. Subluxation, an injury to the tooth supporting structures with abnormal loosening but without displacement of tooth. The tooth is tender to palpation and hemorrhage can be seen at the gingival margin. Treatment includes relieving the occlusion of the opposite tooth and flexible splinting for 10 days. The patient is also advised to stay on a soft diet for 10 to 14 days. Follow-up must be done, both clinically and radiographically, to check for changes. Extrusive luxation is a type of peripheral dislocation and partial avulsion of the tooth. In this case, the tooth is slightly displaced from its socket. Treatment includes careful repositioning of the tooth back to its original position using digital pressure. Then it is splinted for 2 to 3 weeks and the patient is put on soft diet. Follow-up of the tooth is done after 1 year. Lateral luxation, displacement of the tooth in any other direction other than axial. The tooth is repositioned using digital pressure. If forceful repositioning is anticipated, local anesthesia has to be administered to make the procedure comfortable for the patient. The tooth is usually splinted for 2 weeks. However, if there is marginal breakdown, splinting has to be continued for 6 to 8 weeks. The tooth needs to be followed up for 1 year, both clinically and radiographically. Intrusive luxation, also known as the central dislocation, is a type of trauma when the tooth is pushed up into the alveolar bone. Avulsion, also known as extra articulation, is the complete displacement of the tooth out of its socket. Reimplantation in these cases depend on the extraoral drying time. If apical foramen is not closed, endodontic procedures are delayed till the first sign of apical closure can be noticed. The protocol for management of an avulsed tooth with an open apex has been depicted in the flowchart in front of you. In case the apical foramen is closed, endodontic therapy is initiated 1 to 2 weeks after reimplanting the tooth. The protocol for management of an avulsed tooth with a closed apex has been depicted in the flowchart. The last type of injuries that come under Andreasen's classification is injury to the gingiva or the oral mucosa. Laceration of the gingival or oral mucosa is usually due to a tear from a sharp object. Contusion is seen due to blunt trauma to the gingiva or oral mucosa without any break in the mucosa. Contusion is usually associated with submucosal hemorrhage. The last type of injury that we will talk about is abrasion to the gingiva or oral mucosa. This is a superficial wound that leaves a raw bleeding surface. Now that we have discussed different traumatic injuries to the tooth and their management, let us take a look at the prevalence and incidence of traumatic injuries. Prevalence in primary dentition is around 11 to 30%, while in cases of permanent teeth, it varies from 5 to 29%. In permanent dentition, boys are more commonly affected than girls. However, in the case of primary dentition, there is no such sex predilection. In boys, the age group most commonly affected is between 2 to 4 years, and then again at 9 to 10 years. In girls, 2 to 3 years of age is more common. However, it must be noted that most facial injuries are seen in boys between 6 and 12 years of age, and the mandible is more commonly injured than the maxilla. The teeth most commonly injured are the upper central incisor, followed by the lower central incisor. But in case of laterals, the lower lateral incisor is affected more than the upper lateral incisor. The most common type of injury in primary teeth is luxation, and in case of permanent teeth, it is uncomplicated crown fractures. Now, let us look at the treatment options available when the fracture involves the pulp. Pulp capping can be done when the exposure is small in size, that is, less than 1 millimeter, when exposure time is less than 24 hours, and in cases of teeth with an open apex. Pulpotomy can be initiated when the pulpal exposure is large with moderate hemorrhage, and the patient is seen within 72 hours of exposure, and the tooth has an open apex. Apexification is done in cases of non-vital, immature, permanent teeth. Pulpectomy is done in cases where the pulp is degenerated and the exposure time is greater than 72 hours. In the last segment of our discussion, we will talk briefly about the different storage media that is available for storing an avulsed teeth. Every storage media has a few set of properties that is shown in the given table. The most ideal storage media that is recommended is the Hanks Balanced Salt Solution, also known as HBSS. It is commercially available under the name Save a Tooth Solution. In case HBSS isn't available, the tooth can be stored in other media such as diazepam, propolis, and DMEM. Naturally available items such as bovine milk, ORS, egg white, aloe vera, green tea, and milk can also be used to store the tooth. With this, we have come to the end of our discussion on traumatology. We hope this mind map was helpful in recollecting the important points. Thank you.